This is part 6 of the assessment and care of the newborn. We are going to review the physical assessment and findings. The physical assessment will include a complete set of vitals including the blood pressure and a rectal temperature. The nurse will assess for the capillary refill, evaluate for cold stress, notify the physician of elevation or drop in temperature, identify sleep-wake state and correlate with respiration, evaluate for respiratory distress, and auscultate for apical pulse heart and auscultate for breath sounds. If the baby has a temperature at delivery, they may have to be sent to the NICU for evaluation of acute chorio or sepsis. When looking at weight and measurement, you want to plot weight and gestational age on a growth chart. You will measure the newborn's length and their head circumference. The nurse will also obtain daily weights. So what does influence birth weight? Race, mother's diet, if the mom smoked, size of the parents, and interval between pregnancies. Some hospitals also want you to measure the chest circumference and the abdominal girth. We will also be assessing the temperature. The temperature can be attained by the axillary or rectal method. The axillary temperature is the preferred method. Skin probes are also useful to monitor temperature. Usually the temperature will stabilize by 8 hours of age. If the neonate experiences a temperature instability, this may indicate an infection. The nurse will monitor the temperature every 30 minutes until stable for 2 hours, and then it will be conducted every 8 hours. The axillary temperature should range from 97.5 Fahrenheit to 99 degrees Fahrenheit. Rectal temperature should range 97.8 Fahrenheit to 99 degrees Fahrenheit. The best thing you can do for a baby is crank up the temperature at the time of delivery so the room is toasty when the mom delivers. Then keep the baby skin to skin with the mama. If that baby gets cold, you're going to be in a mess. Babies can die from being too cold. Remember that if you ever assist with the delivery in the emergency room or grocery store parking lot, keep that baby warm at all costs. Okay, so when assessing the skin and hair, you want to assess skin for acrocyanosis, modeling, erythema, toxicomylia, pigment, jaundice, overall color, vernix, and peeling. Be sure to examine for petechiae or forceps marks. Assess for ecchymosis, location, and amount. Examine the texture and distribution of the hair. Look for birthmarks, stork bites, Mongolian spots, port wine stains, hemangiomas, cafe au lait spots, and jaundice. Newborns with choanal atresia, which is blockage of passageway between the nose and pharynx, will be cyanotic at rest, pink when crying. If crying increases cyanosis, then check for heart and lung problems. They will be very pale newborns. They could be anemic or have hypovolemia. Acrocyanosis is normal for about the first 24 hours. It's caused from poor circulation. Mottling may be due to prolonged apnea, chilling, sepsis, and hypothyroidism. Causes a lacy pattern of dilated blood vessels in the skin and usually a result from circulation fluctuations. Harlequin sign is one side of the baby is red, one side is pale, lasts up to about 20 minutes. It represents a vasomotor disturbance that's usually transient and insignificant. The later the baby, the less vernix. Remember, newborns should not be jaundiced before 24 hours of age. If they are, then report that to the pediatrician right away because this is a pathologic jaundice, not the normal physiologic jaundice. Here's an image depicting a newborn experiencing acrocyanosis. You note the bluish discoloration of the extremities. Here's an image of a newborn with erythema toxicum, also known as newborn rash. It could be normal, it flares up, then calms down. It's usually widespread. Here is a newborn that is experiencing the stork bites, aka telangiectatic nevi. It's usually found at the nape of the neck, the bridge of the nose, the eyelids, or the lower occipital bone. They usually fade by second birthday. There is no clinical significance. Here's an image of a newborn that depicts milia. It appears like little white heads. They'll clear up on their own within a month. Some of the older generation will refer to them as a milk pimple or milk bumps. Then we had the Mongolian spots. They're common among Asians, Hispanic, and African descent babies. It can be seen in about 1 to 9% of Caucasian babies. They gradually fade out by the first to second year of life. Then we have the port wine stain. It's a cluster of capillaries beneath the skin. It's flat because it's beneath the skin. Does not fade, will not blanch. It's common on the face. These won't grow with time nor decrease in size with time. You want to watch for neural problems that may or may not accompany port wine stains. If neural problems do exist and the baby has a port wine stain, the baby may have Sturge-Weber syndrome. Then this image of the newborn depicts the nevus vasculosus, also known as a strawberry hemangioma. Strawberry hemangiomas may appear anywhere on the body but are most common on the face, the scalp, the back, or the chest. They consist of small, closely packed blood vessels. They may be absent at birth and develop at several weeks. They usually grow rapidly. It remains a fixed size and then it subsides. In most cases, strawberry hemangiomas disappear by the time a child is about 10 years old. Some slight discoloration or puckering of the skin may remain at the site of the hemangioma. This concludes part 6 of the assessment and care of the newborn.